Hello. First, I'd like to thank you to organizers of the conference and for the Mr. Chairman for inviting me to deliver this brief presentation about the neuroimaging studies in chorea and Huntington's disease. Let me kindly introduce myself at the beginning. I'm a neurologist working in the first department of neurology at the Institute of Psychiatry and Neurology in Warsaw, Poland. I am also a principal investigator of the Huntington Disease Center, which is located in my institution, and this is multidisciplinary unit composed of staff from the first Department of Neurology and Department of Clinical Genetics. We participate in different observational, clinical, and scientific projects in Huntington disease, and for every year, we are following up about 600 patients with Huntington's disease, both symptomatic and pre-symptomatic patients. Today, I'd like to briefly tell you about the role of neuroimaging in the diagnostics and scientific studies of Huntington's disease. The question is, what is indeed the role of neuroimaging in such type of disorders? Well, the first point is that it can be used in differential diagnostics in search of chorea etiology. In general, Huntington disease is not difficult to diagnose, especially when we have an information about the family history of the patient and we have a possibility to do a genetic testing. However, in rare cases, the family history is not available, or the clinical presentation is not fully typical for Huntington's disease, or patient is tested for the Huntington's disease, and the result of this test is negative. In such cases, we can use neuroimaging as a helpful tool to perform a differential diagnostics of chorea etiology. For Huntington's disease and other genetic choreas, neuroimaging may serve as the study that delivers biomarkers of the disease, which can be used as a potential endpoints in different neuroprotective trials. Last years are years when there are a lot of new trials of drugs that may possibly influence the disease progression. So, all investigators need a reliable biomarkers that can be used to track the disease progression and to assess the effectiveness of these new drugs. So that is another important function of the neuroimaging. And also, neuroimaging might have a very scientific function to help us to understand better the pathophysiology of the disease and to search for correlations between the structural or functional neuroimaging changes and the clinical presentation of Huntington disease and the progression of motor or cognitive dysfunction. There are a lot of potential diseases who have a presentation of. Do you see me? Sorry. Okay. For a moment, I thought I lost my internet connections. There are a lot of disorders which also may present with chorea. Among them, neurodegenerative disorders, which are inherited, may have an autosomal dominant inheritance, autosomal recessive inheritance, maybe of mitochondrial inheritance, and also maybe, for example, X-linked. For autosomal dominant, the most popular neurodegenerative disorders presenting with chorea is, of course, Huntington disease. But we have also another disorders, like, for example, HD-like syndromes of some kinds of spinocerebral ataxias, especially a spinocerebral ataxia type 17, which might present with chorea even more pronounced than cerebral symptoms. In case of autosomal recessive disorders, we have disorders which may be caused by the accumulation of ferrum into basal ganglia, but also such disorders like Friedreich ataxia or Wilson disease might also have a chorea in their clinical symptoms. In case of mitochondrial disorders, for example, MELAS, chorea was also described. And there is a classic X-linked neurodegenerative disorder, which is called MacLeod syndrome, which presents with predominant chorea. However, chorea may be also present in many other autoimmune, for example, autoimmune cerebral processes. It was described as a part of clinical presentation of, for example, lupus erythematosus, antiphospholipid syndrome, different paraneoplastic syndromes. And also it was described, chorea is present in some children autoimmune disorders like Sydenham chorea or the PANDAS syndrome. Chorea can be also induced by different vascular disorders of the brain, can be, for example, present after stroke or caused by different metabolic disturbances, like for example, non-ketotic hyperglycemia, stereotoxicosis, or uremia due to kidney insufficiency. Therefore, we have to think and we have to ask the question, what is the pathophysiological basis of this symptom? And we have to search it in basal ganglia, especially in the structure which is called striatum. It is a part of basal ganglia and it is composed of two subcortical nuclei. The one of them is called caudate nucleus and the second is putamen. They together create a structure which is called a striatum, and the striatum is an important part of the neural circuit, which is responsible for the control of movements. Basal ganglia are responsible for control of movements, of fine-tuning of information going from the cortex, and the effect of this tuning is to increase or to decrease the speed of the movement. So this neural circuit is responsible for the correctness of movement we perform. And that neural circuit is composed of such elements like striatum, like globus pallidus, like subthalamic nucleus, and the thalamus. Information about the movement leaves the cortex, then enters the striatum, goes to the globus pallidus, to the thalamus, and goes back to the cortex corrected, enhanced or usually enhanced or sometimes suppressed. In case when this neural circuit doesn't function correctly, we can observe the different movement disturbances or different movement symptoms. In case of the damage of the striatum, we usually observe so-called thalamic overstimulation of the cortex, and the effect of this thalamic overstimulation caused by the damage of the striatum is the generation of the involuntary movements. So the conclusion of that slide and of knowledge about that circuit is that we have to search for the real causes of chorea, especially in the striatum. And different presentations of striatum in different diseases might show abnormalities located within this basal ganglia. For example, in case of diseases with inherited neurodegenerative diseases, usually we observe the atrophy of the head of the caudate nucleus. Such atrophy is, the caudate nucleus is located here when I show, that is located just near to the anterior horns of lateral ventricles. And usually, in the case of neurodegenerative disorders, the atrophy of heads of caudate nucleus is symmetric and leads to enlargement of lateral ventricles, giving them a shape of the butterfly wings. This is shown here on the slide of the MRI of patients with Huntington disease. However, in other neurodegenerative disorders, similar abnormalities are also present. For example, in patients with chorea acanthocytosis, when also chorea is a main presentation of the disease, we also observe the atrophy of caudate nucleus. Also in McLeod syndrome, which is a disorder connected to X chromosome and also leading to chorea, this atrophy of caudate nucleus is also very pronounced and symmetric. In case of other disorders, like for example, spinocerebellar ataxia type 17, with the presence of choreic movements, we also see usually a pronounced atrophy of caudate nuclei, but usually this atrophy is accompanied by the severe atrophy of cerebellum. So patients present usually with cerebral symptoms together with chorea. Also, another disorders may be presented with chorea, like for example, autoimmune disorders. On this slide, I present a case of present an MRI of patient who was diagnosed with anti-glutamic acid decarboxylase antibodies related chorea. And in these patients, we found a multiple small lesions located in the basal ganglia. In case of rarely seen currently Sydenham chorea, also it is frequent finding hyper-intense lesions which are located in the heads of caudate nucleus. So in such case, we do not have an atrophy, but rather hyperintensity, which is located within the head of caudate nuclei. In case of diseases, in case of such diseases like neuroferritinopathy, we can observe asymmetric hypointense signals which are located in heads of caudate nucleus and also in globus pallidus, which are result of the accumulation of ferrum within this basal ganglia. Also, it is described that in some cases of Farr disease, massive calcifications located in the basal ganglia may also induce choreic symptoms, and these choreic symptoms sometimes are also observed. Also, in case of vascular cases of chorea, we can observe mostly vascular changes which are located unilaterally or bilaterally in the basal ganglia, and chorea, which is a result of vascular disorder, usually characterized with the rapid or acute onset and frequently is unilateral, so it is limited to the one part of the body. Here is an example of patient who was